Hello everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly for SAXE Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar. Are high-flow oxygen therapy and non-invasive ventilation complementary for acute respiratory failure? And now, I'd like to introduce you to Dr. Ruben Restrepo, who is our moderator today. Dr. Restrepo is Professor and Coordinator of Research for the Division of Respiratory Care at the University of Texas Health Science Center at San Antonio, Texas. Trained in medicine in Medellin, Colombia, Dr. Restrepo went on to academic positions at Georgia State University and then at the University of Texas. He has published widely in the field of respiratory care, including book chapters and articles, and has given many presentations. He is a reviewer for several major journals in respiratory and pulmonary medicine, and is the recipient of many honors and awards for his teaching, publications, and volunteer work. Dr. Restrepo, welcome, and I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Yes, I am. Thank you, Emily, for that kind introduction. Good morning, good afternoon, everyone. It is a pleasure to be here with you today. The title of today's webinar is Are high-flow oxygen therapy and non-invasive ventilation complementary for acute respiratory failure? And speaking today on this very timely topic is Dr. Javier Belda. So it's a pleasure to introduce Dr. Belda, who is a professor of anesthesiology at the Department of Surgery in University of Valencia, Spain, a member of the Education and Training Committee and the European Society of Anesthesia Subcommittee, past member of the Respiratory Subcommittee and Critical Care Program of the American Thoracic Society. He has participated in more than 40 national and international projects focused in ventilatory strategies for prevention and treatment of lung injury. He's editor of 15 books and author of more than 220 research papers, and he's a reviewer for JAMA, Lancet, Anesthesiology, EGA, Critical Care Medicine, and other high-impact journals. Speaker has disclosed the following relevant financial relationships: grants and research from Early Kid from Philips, consultant for Paulson, Getinge, Philips, and also scientific advisory board for Paulson, Getinge. I just want to remind everyone that this educational activity is approved for 1 contact hour for nurses and respiratory therapists, and that important support has been provided for this educational activity by Philips. And now it is truly my pleasure to turn it over to Dr. Belda. So Javier, this is your time.
Thank you very much, Ruben. It's my pleasure and it's an honor to be in front of such a big audience in this webinar. My English is a little lousy, but I'll try to make myself understood, okay, for this presentation. Okay, let's go ahead to this very trending topic, as you said, it's high flow oxygen therapy and non-invasive ventilation in acute respiratory failure. So for today, learning objectives are related to the effects of high-flow oxygen therapy, because if you don't know how it works, physiologically speaking, you never will applicate it in a right way. So a second part is to show the evidence for the use of the high flow in acute respiratory failure, and finally to describe the effects and outcomes of all these techniques related, which are high flow, non-invasive, and conventional oxygen therapy. Okay, so starting with the main effect is to provide a constant FiO2. This is a paper showing how the FiO2 is related to the flow of oxygen that you receive through the cannulas. Look here, this is a bench study, and look here, the graph. This is, if you select an FiO2, you see that using 2 liters per minute, 4 liters, or 5 liters, you get a different FiO2 with nasal probes, you know very well that. But look at the effect of tidal volume. If the patient is breathing from 300 to 700 milliliters, you know the amount of oxygen is really different from here, from this point to this point. Okay. But look at what happens with high flow. When you are adjusting high flow 20 liters to, yeah, the arrow is here, yes. When you use 20 liters to 60 liters, this is for FiO2 of 70%, and then this is for FiO2 of 30%. You see that the FiO2 that is delivered is quite constant, is almost independent of the tidal volume of the patient. So this is the first and very clear effect when you use high flow nasal cannula, that is a quite constant FiO2 in spite that the patient is breathing through the nose to the mouth. So you are delivering a constant FiO2. So the second effect, which is also very well known, is the positive pressure that you obtain when you use high flow nasal cannula. This is another bench study using 3 different types of devices to deliver high flow therapy to this, let's say, a model. And you can see here in these 3 models, this is one, this is the AirVo, this is the T75. Look at the effect of the positive pressure that is created when you increase the flow from 0 to 50 liters per minute. You can go with the AirVo from 0 to 60 liters per minute, obtaining this pressure. And here again, up to 80 liters, look at the pressure that you obtain is more or less around 4 centimeters of water. There is also a different effect according to the compliance of the patient, or you can just to, foresee something like that. But this is not a big effect. Look at the difference between the 3 different devices in 3 different compliance, and the effect, the pressure that you obtain with low compliance is that the pressure is around 2 centimeters of water. Okay, and the third effect is the positive pressure is, I would like to show, is that this effect, we apply the high flow in different patients, in 30 patients after extubation in cardiac surgery, and you have here the effect on, this is the tracheal pressure, and this is the transpulmonary pressure. Each line of the graphs is related to one patient. Look, when you increase the flow from 30 to 60 liters per minute, you look that the pressure at the tracheal level increases, but look at the different response of the different patients. If you look at the transpulmonary pressure, the behavior is different according to the patients. You look, this one is going from almost nothing. This patient was moving very high in pressure in about 4 centimeters of water. But if we take this is the overall effect, look at the difference between 30 liters per minute and 60 liters per minute. In the tracheal pressure, you see that the pressure increases according to the flow. And also some increase is seen in transpulmonary pressure. Okay, and finally, if you look only to, when you compare only 30 to 60 liters per minute, look at the tracheal pressure. The mean tracheal pressure increases from around 2 centimeters of water to around 5 centimeters of water. The transpulmonary pressure also increases. The increase is very slight, but there is an increase as well. But remember that this is just the mean of the effect. You remember that they were patients with different behaviors when you increase the flow, from no effect to a very high effect. Okay, so the conclusion of this work that we did, and this in the way of be published, is that the tracheal and transpulmonary pressure increase with flow. But however, there is an unpredictable response because it's very heterogeneous response according to the patients. Okay, the next effect is if there is a pressure, what is the effect on the work of breathing? This is a nice paper only in 15 patients with, let's say, respiratory failure, PF ratio below 300. They were looking at the blood gas analysis, inspiratory effort, and work of breathing in terms of the changes in esophageal pressure and pressure time product. So look here that the patients with the PF ratio increases in general, when you compare the mask with the high flow. So look, the overall effect is coming from here about 110 to here 170. So there is an increase in PF ratio. That's good, So, but you can see here that delta pressure, which is related to work of breathing, delta pressure was reduced in most of the patients. The effect in the mean effect is not very big, but there is some effect reducing the work of breathing. When you see the lung volume, because all these effects are related to an increase in lung volume, the lung volume increases a lot in one patient, but not a lot in many others. So again, what you see is a clear effect, but very heterogeneous response with the patients. This again, another paper related to the respiratory work of breathing, looking at the electromyography of the diaphragm, and you can see patients here with high flow, then they move to conventional oxygen therapy, and then to high flow, and you see that the electromyogram, diaphragmatic electromyogram, increases, indicated an increase of the effort when you use conventional oxygen therapy, and decreases when you move from conventional therapy to high flow. The same is related to the pressure time product, and look that the increases pressure time products indicating high work of breathing, and then is reducing the work of breathing again with high flow nasal cannula. Okay, which is clear is that the effect of the positive pressure can reduce work of breathing. And this is the last effect that I would like to show you, is that is related to CO2 removal, to enhance CO2 removal. This paper, this study was performed on healthy volunteers and 3 tracheostomized patients. They use potassium, let's say it was here the potassium 81, sorry, and you can see at the scintigraphy this is a normal situation during exhalation. The CO2, labeled with potassium, go out the lungs, and then you can see a lot of CO2 going out the nose and then outside. So look at the control group here, and you can see there is a lot of CO2 going out and in and out, and filling all the oral cavity, the nose, and also the oropharynx. And but when you use high flow nasal oxygen with high flow up to 45 liters per minute, look at how the CO2 is removed from all the nasal cavity and the oropharynx, right? So only CO2 is seen in the trachea. The results on the 3 patients, the 3 tracheostomized patients, are presented here. So this is the inspired tracheal CO2, and you see how CO2 is reduced from baseline to high flow 15 liters per minute, a more clear reduction when you use high flow of 30 liters, and even a more reduction when you use high flow of 45 liters per minute. Related to this lower inspired tracheal CO2, there is an increase in inspired tracheal oxygen. There is more place for oxygen and less place for CO2. And this is related to the overflow that is created because of the high flow in these areas. So let's go to make a summary of these physiological effects of the high flow nasal cannula. So the first one that is very clear is that you control FiO2. You set FiO2, and in spite of the tidal volume of the patient, in spite of the effort, in spite of everything, FiO2 is very well controlled. And you don't have that effect when you use a venturi mask. You know, it depends on the inspiratory flow, depends of many other things, and the FiO2 is best controlled using high flow nasal cannula. A second effect is the positive airway pressure. This is like a CPAP effect, but you have seen that this CPAP effect is not very high. It's around 4 centimeters of water, maximum at 5 centimeters of water. So there is some positive airway pressure effect. The third point is that related to this positive airway pressure effect is a reduction in the inspiratory effort that we have seen in 2 papers, and work of breathing maybe. So it's clear that when there is positive airway pressure, the effect is there, there will be a reduction in the effort and work of breathing. So the relation between airway pressure and inspiratory effort is very clear in non-invasive ventilation, and also here, but just related to the different type of patients. Finally, there is an effect for reducing dead space because improved CO2 elimination. More than that is a clearance, enhanced clearance of CO2 from the nasal and oropharynx place, and this enhances the CO2 elimination. So these are clear effects. The point is that these effects are presented in a different magnitude. It's related to maybe the device and the flow as well, mainly to the flow, and at 20 liters per minute, these effects are only related to FiO2 control. But if you increase the flow up to 60 or even 70 or 80, you have a better response in positive pressure, reduction of the effort, etc. So factors are more related to the patients that to the flow. So at a constant flow, there is a different effect in different patients. So the point is that you cannot, maybe you cannot predict what is the response in every patient. You know, some of them have the open mouth, other the mouth is closed. So tidal volume, the mechanics of the lungs and the effort. So from my point of view, the response, the only point is that all these effects are non-predictable in magnitude. Are there, but the magnitude is not clearly predictable. Okay, go ahead with that, you know, because I'm going to change and to start the story, because this was a nice story which began in 2 clear papers published in JAMA in 2016. So what's the effect of high flow nasal cannula on post-extubation respiratory failure? In the first one, they compare the high flow with conventional oxygen therapy in patients at low risk of reintubation, okay? And in the second, they compare high flow with non-invasive ventilation in high-risk patients for reintubation. So it's nice to see the results because they were, you know, clear, and was for every one of us was like a light, you know, in the night. Look at these results. Look at the reintubation. All-cause reintubation was different from high flow to conventional, for coming through 5% to 12%. So they concluded that was a significant difference. They concluded that among extubated patients at low risk for reintubation, the use of high-flow nasal cannula oxygen compared with conventional oxygen therapy reduced the risk of reintubation within 72 hours. So was clear a superiority of high flow versus conventional oxygen therapy in low-risk patients with respiratory failure after extubation. At the second, you remember the second was in a high-risk patient, and they compare high flow with non-invasive mechanical ventilation. If you follow here the numbers, reintubation moved from 19% with non-invasive and 23% with high flow. The difference was not statistically significant. And they conclude that the high-risk adult patients after extubation, high flow was not inferior to non-invasive ventilation. So this is the way to look at the bottle being half empty or half full. So for my point of view, these results are telling you that there is something there that we cannot see very well with this study. And this is like that because if you look at the following publication, there was a very nice, editorial in Minerva Anesthesiologica that was pointed. This editorial was pointing out, the studies by Hernandez. They were in the editorial. They were asking, what are the optimal settings and the best duration for use of high flow nasal cannula? Because they were not as clearly stated. So there was a failure, or before the failure was just for pre-treatment or treatment or preventive. So the second is, when is the best to apply it? Is preventively or after the failure? So it was not clear in these two studies. Which could be the best alternation? Why don't you use first non-invasive and then high flow, or first high flow and second non-invasive? So it's not clear what is the order for application. Should we expect to see benefits using both high flow and non-invasive? Why not? They were asking as well the criteria for follow-up. How do you reduce the support? Yeah, it was not stated in these two papers that I have shown. So just remember that there is a clear indication for non-invasive ventilation when you compare to conventional oxygen therapy. This is a paper published in Intensive Care very recently, just showing that reintubation rate when you compare non-invasive versus standard oxygen therapy, there is a significant superiority of non-invasive ventilation. It's 1, 2, 3, 4, 5, 6, 7 papers telling the same story. It's the point that we know very well that it is like that. So let's move a little, because this was a very important paper that was also, very, very, it was let's say a astonishing article published in the New England Journal of Medicine. It's 310 acute respiratory failure patients, but acute respiratory failure, non-hypercapnic, no COPD, some of them heart failure, but awake patients, Glasgow Coma score above 12, and they compare high flow, conventional oxygen therapy, and non-invasive ventilation. The primary outcome was the intubation rate, right? So this is how they performed the study, that about 2,500 patients with acute hypoxemic respiratory failure, and they finally recruited 313 for randomization, when 100 for each group, 100 high flow, 100 standard oxygen therapy, and 100 non-invasive ventilation. So it's a very good study group, and let's look at the results. Okay, look at this. This was what happens, on intubation rate. The overall population, you see that cumulative incidence of intubation. So the intubated patients, the cumulative incidence was higher in the non-invasive ventilation than to standard oxygen therapy, with a slight difference, but the less proportion of intubated patients were those on high flow. I say maybe this is because they were really the patients, very sick patients. They, the non-invasive ventilation is more effective in these patients. And no, it was not like this. They look at that, patients with PF ratio below 200, and the result was even more clear. Look here. That they intubated patients more frequently, the patients treated with non-invasive ventilation as a primary option, then to conventional oxygen therapy, and then finally to high-flow oxygen. That was the best. So after that, you were looking at a detail, what happens exactly with the data. Look here, that intubation rate was 38%, 38% of the patients with high flow, 47% with standard oxygen therapy, and 50% with non-invasive ventilation. In any case, the difference was not significant. So the real situation was they didn't find, statistically significant difference in this population for intubation rate. So the second result, you remember, that was death in ICU. Death in ICU was here, look here, 11% with in high flow, 19% with standard oxygen, and 25% of non-invasive ventilation. And this was significant difference. And they concluded with this that high flow improved the survival rate among patients with hypoxemic acute respiratory failure, even though no different intubation rate, that was the primary outcome, no difference was observed with high flow as compared with standard oxygen and non-invasive ventilation. So let me have just one my thoughts on this study. So the study was not powered for difference in mortality, and the mortality was the first conclusion. I don't like this type of conclusions when there is no when the study is not powered for that. The main outcome was the intubation rate. Okay, so the second point is that it was excessive number of patients excluded. If you can't remember the first slide, but it was more than 2,000 people, with respiratory failure, and they just recruited 300 out of more than 2,000. This is a very small recruitment. So this is another, it's my thoughts. I'm still thinking, maybe non-invasive treatment was suboptimal. So there is also treatment overlap between the groups. So, patients with low frailty index, which sometimes are more frequent in our clinical at the bedside, they were not included. So a lot of problems with this paper of Frat, but was a very striking paper. Just remember that when you compare non-invasive ventilation with in acute hypoxemic respiratory failure, in this meta-analysis in 11 study, like the other paper, like the other patients that we have seen in the last paper, no COPD patient, no cardiogenic pulmonary edema. So look at this, was published in Critical Care. The intubation rate was beneficial in the patients treated with non-invasive ventilation. Clearly, you can see here in the forest plot. And then the mortality was inferior with non-invasive ventilation when compared with a standard oxygen therapy. So it's a problem. What's wrong with these results? We have seen that the Frat paper is telling that the intubation rate and mortality is higher with non-invasive versus standard oxygen therapy and high flow, but then we know in the same year, in a different meta-analysis, that the mortality is less, maybe not I mean, not a big difference, but which is clearly less is the intubation rate when you, in the same type of patient, when you compare with the standard oxygen therapy. What's happening with these papers? What's wrong in this situation? So it's very clear for me. Just go to the Cochrane library, looking at high flow review when you use high flow for respiratory support in intensive care patients. I want to show, this is the analysis that the sources of bias which are stated in the Cochrane library for the high flow oxygen therapy. Look at this, that very good papers have all these risk of bias in green, so no risk of bias, low risk of bias, okay? And look at this, there is a lot of, yellow and red of, blinding is not very good, incomplete outcome data, so selective reporting, other biases. So it's like that, reporting that, the biases in the studies have been too high for my point of view, but also when you look at other publications, this was a quite nice publication on a systematic review in critical care medicine, looking at the quality of the evidence of the papers. And look at here that they said that the risk of bias was serious when they analyzed mortality and when they analyze intubation. The risk of bias is serious. If it's serious, maybe the paper are not that good, So these are the results shown in critical care medicine. Look at here, the hospital mortality, when you compare high flow with usual care, there is no difference, in mortality. And when you compare high flow versus usual care with intubation rate, there is some advantages for high flow therapy, but just remember that the risk of bias here is very clearly stated. Risk of bias C, which is blinding of participants. If there is no if the study is not blinded, maybe you choose the patients, you choose the moment that you collect the data, and you choose many other things, and this is a high risk for show the results. So finally, to say that in this type of meta-analysis, the required information size is not reached yet. So only 30% in the statistics of mortality, and 62% in intubation rate for reaching the numbers needed to conclude a real benefit on mortality or intubation rate. So the other point, a big point for critical care, was they had very heterogeneous severity of acute respiratory failure patients. So, but not only that, I think that we have a lot of questions, even today, on high flow, because, okay, when to use it? Yes, post-extubation, okay, correct, I know that, we can see the effect of intubation rate, we have seen some papers, but to prevent respiratory failure or to treat respiratory failure, what is the effect on escalation therapy? How we move from high flow to normal oxygen or to non-invasive ventilation? But again, another point is more efficient in surgical population or non-surgical, in hypoxemic or hypercapnic respiratory failure, in emergency settings or intensive care unit? Could we use high flow alone or combine it with non-invasive? There is a lot of questions that are not yet answered. Okay, but I would like to show you some papers on that. This was, look at, these are patients with after cardiothoracic surgery. So they are surgical patients. Look at, this is the patients without treatment failure. So, but anyway, look at the failure when you use high flow versus BiPAP, the failure was exactly the same. So was no difference at all when you compare BiPAP versus high flow. And there is a lot of patients. So, but if you pay attention to the treatment is for BiPAP was only 4 hours per day, 8 hours in 4 days. So it's difficult to see what are the problems in this type of studies. So is the type of patient, is the protocol, because they didn't show differences between BiPAP and high flow nasal cannula. So it's very difficult to understand here what is the real effect, because it's not the patient. These are patients after cardiothoracic surgery, but maybe it's not the patient, but the protocol that they use. Okay, so, and this is another meta-analysis in which they use acute respiratory failure in 18 control studies, high flow versus non-invasive versus conventional oxygen therapy. And they were telling that in patients with acute respiratory failure, and this is very important, you know, the reliable alternative to non-invasive ventilation. So non-invasive ventilation is maybe the first option. So the more reliable alternative is high flow instead of conventional oxygen therapy. They were looking at the results of the forest plot, and when they compare high flow to conventional oxygen therapy, they saw that the high flow was better. When they compare high flow versus non-invasive ventilation in the rate of endotracheal intubation, so the effect was not that clear. So I'm just telling that, looking at the results, I think that high flow is always better than oxygen therapy in any case, but high flow is not clearly superior to non-invasive ventilation for all patients. So this is to finalize the criticism to the papers. This is a very, very recent meta-analysis published in emergency medicine. So they compare non-invasive, high flow, or a combination of both. You know, primary outcome was intubation or re-intubation in the treatment arm. You know, look at they just collected 3 papers, 3 good papers to make the comparison. Why? Because they found a high heterogeneity in patient population and severity. The treatment was really different when you compare the studies. Difference in intubation or extubation phase at the start of the study. Difference in reporting the primary outcome. A nonsense adoption, a non-inferiority study design. Why non-inferiority? Why don't you demonstrate that high flow is superior to the rest? I accept. So they were just concluding that the clinically and statistically invalid to pool results for the included studies. And this is a recent meta-analysis. So again, it's telling that the studies are not clear. What is clear right now? From my point of view, there are a few things that are clear. Maybe the first one is what is happening when you use, you know, in a standard way after operation in patients in postoperative care unit. This is a nice paper. It's the OPERA study done in Europe, you know, in patients after surgery and with moderate high risk of postoperative pulmonary complications. They compare high flow to standard oxygen therapy, and what they obtain when they apply to all these patients, look at the perioperative hypoxemia, you know, after extubation, pulmonary complications in 7 days. They concluded that the high flow nasal cannula did not improve pulmonary outcome compared with standard oxygen therapy. They applied routinely to these patients just at risk of pulmonary complications. If you apply to all of them, you are not going to find any difference. So maybe the selection of the patients is the best thing to bear in mind when you are going to apply high flow oxygen therapy. And a second thing is that this very, very recent systematic review in a meta-analysis from a very well-known group of people, including Karen Burns and Laurent Brochard, Jordi Mancevo, good friends of mine, all of them. And it's published in Intensive Care Medicine 2019, so including 2,000 patients. Look at the table number 1 was the individual study risk of bias. They were looking at the risk of bias of the publications. So when they were looking at the results, they published, in general, the first plot is the forest plot for mortality. Of course, there is no effect of mortality when you compare high flow to standard oxygen. I never expect that, to improve, survival. But when you look at the study subgroup, when you look at the increasing in therapy from oxygen or high flow to intubation of the patient, so escalation of the therapy. So they divided the meta-analysis into studies with low or probably low risk of bias and high or probably high risk of bias. Look that the effect is better with the low probability risk of bias, but the effects are quite similar. So in overall, when you compare high flow to a standard oxygen therapy, with low risk of bias, there is an effect. So 2 things clear. Don't use routinely, and when you use in patients with respiratory failure and the need for invasive mechanical ventilation, the risk is less when you apply high flow oxygen therapy. So maybe this is the reason that JAMA published in July 11 that high flow nasal cannula is not just another nasal cannula. Yeah, we know that today that this is like that. A little late they said that, but they based this commentary in the meta-analysis published in 2017 of NIV, telling that, compared to high flow and non-invasive and conventional oxygen therapy, suggested that high flow performance similar to other non-invasive ventilation and outperformed conventional oxygen therapy. So from my point of view, again, so what's the difference between high flow and non-invasive ventilation? From my point of view, is the ability to exactly set the parameters. What I'm trying to say, this is the comparative effect of the devices, and this is why I'm focusing on the complementary of the techniques when you know how to apply it. Okay, FiO2 is correct in conventional oxygen therapy, but for an exact setting of FiO2, high flow and non-invasive ventilation are both working similar. Okay, but if you need a CPAP effect, high flow produce some CPAP effect, but if you want to titrate the level of CPAP, you need to go to non-invasive ventilation. But if you want to have a BiPAP effect, that is to say, to ventilate the patient, high flow cannot ventilate the patient. You can ventilate the patients to reduce CO2, really reduce CO2 using non-invasive ventilation. CO2 clearance is anyway some clearance when you use high flow, but you clearly know that with non-invasive ventilation in COPD patients, you reduce CO2 very well. So look at this table. This is the way to see the complementation of the 3 techniques. Standard patients, why not start with conventional oxygen therapy? Because they are at risk, high risk or low risk. High risk, and I would apply, let's say, 5 centimeters of water of CPAP. 5? If you need to apply 5 centimeters of water of CPAP, go to non-invasive CPAP. with face mask adjusting 5. Because if you go first to high flow, maybe you have 5, but it's very rare. You can have CPAP effect up to 4 centimeters of water. Maybe if you feel that 4 centimeters of water is correct, go to high flow first and then to non-invasive ventilation. But if you need BiPAP, don't, I mean, that's clear. There is a, mechanical failure in the patient, go to non-invasive ventilation directly. Okay, and this is the, this is the study. And this is the study, but the point is that the results are not published yet. Was published, this protocol in British Medical Journal 2017 is looking at the reintubation rate in patients at risk of, respiratory failure. And they compare high flow versus a combination of high flow with non-invasive ventilation, which makes sense, and use of that more than 12 hours per day. So this is, clear. You cannot compare, standard oxygen therapy with 2 hours of BiPAP. No, this is not, if you need BiPAP or you need, so this combination sounds nice, when you use non-invasive ventilation, maybe there is the rest period of the patient. Instead of a standard oxygen therapy, why don't you use high flow nasal cannula? This makes sense, right? So the hypothesis of reintubation rate is 18% for high flow versus 10% for high flow plus non-invasive ventilation. I think it's a very good study, and let me conclude right now telling that clearly there is no predictable effect in high flow except for FiO2. But what we know as well is that there is no harmful or adverse effect related with high flow. The truth is that the comfort is better and the tolerance is better when you compare high flow to non-invasive ventilation. But it's very important to select the patients. Okay, high flow seems more effective than nothing, that conventional oxygen therapy, but looking at the the papers that we have right now, maybe there is a risk of bias. So be careful with when you apply high flow nasal cannula and select the patients. So you can use it at a first alternative to standard oxygen therapy. That's clear, but you have to monitor the patient. To monitor the patients because you may need to escalate the therapy. Finally, if you feel that you need a titrated positive pressure, I mean, you need 7 or 5 or 8 or please, or control minute ventilation, apply non-invasive ventilation. That's it. Thank you very much. I would like to thank all of you staying there for this long talk, and I would like to send back the microphone to Ruben, to Professor Restrepo, which is the moderator. Thank you very much, Ruben.
Oh, you're very welcome. Actually, just thank you so much. That was a great presentation on. This topic is as hot as it could be. So we're going to have just a few questions a little bit later. Let me just remind you that this educational activity has been approved for 1 contact hour. And to obtain these credits, you need to go to saxtesting.com /BO, and you will need to register at the site. Complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. And I want to thank Philips for giving this support to this extra educational activity. So now we have a few minutes for questions, and I think we've had just several of them. Javier, let me go ahead and start with one of them just sent by Irina. So the question by Irina is, could we develop a tool to measure tidal volume, breathing pattern, effort, etc., to try and figure out how to predict a positive response to high flow oxygen therapy?
Oh, okay. We could, but the point is it's quite difficult because only the positive pressure, only to measure positive pressure, you should have, a catheter in the trachea. So no, my answer is not at the bedside for everyday care. So it's not difficult, but impossible. So for the studies that we did, we put a catheter after the extubation. We left a small bore catheter inside the trachea for make the measurements. So not for a daily clinical practice.
Okay, perfect. So we hear from others that high flow or high velocity can replace BiPAP, but our clinical reality paints a different picture, and we use the two back and forth when patients need a break from BiPAP. So how should we make sense of others saying that high flow can replace BiPAP?
No, they make no sense. Absolutely. So no, you're totally right. So no, you are applying in the right way. I think that the both techniques, because as you can imagine, all of us have our experience with non-invasive ventilation, and when a patient needs non-invasive or even intubation, right? A patient with acute respiratory failure that need to be intubated because is not tolerating non-invasive ventilation, you know exactly what was applied, and if you are applying, let's say, a BiPAP of 14 and 10, so this cannot be replaced by high flow nasal cannula. You'll never obtain that. So don't pay attention. I spent almost the whole of the talk telling that don't trust this reality that is published in the papers, because the risk of bias is very high.
Yeah, I wanted to make a comment on that because I think for the longest time we used to separate clearly high flow oxygen therapy being oxygen therapy and non-invasive ventilation, everything that includes the delivery. I mean, it's the conscious, delivered, measured positive pressure ventilation. But I think just very recently, the FDA has approved these devices as non-invasive ventilators, or just a form of non-invasive ventilation. And to me, I think it's very clear what the confusion is. Even though you have benefits on clearance of CO2, clearly they should be completely separated.
Totally agree. I think that's quite clear.
Okay, I have a question in regards, actually this coming from Rena again, but this is actually very important. Are we introducing higher risk to the patient if high flow oxygen is delaying intubation? Even when reintubating, isn't there a risk of treatment is delayed?
And the question is very good, because maybe you remember very well that we tell that when non-invasive ventilation is maintained, you know, more time that required, and you intubate the patients, patients diet, you know, after reintubation more frequently that if you intubate the patients in an early phase. So this is, the question is correct. And this is the same, maybe will apply to this. So you can use at the first time, you can use at the first instance, you can use high flow. But yeah, close monitoring to the patient, you know, your respiratory frequency, dyspnea, the movement of the rib cage, you know, the movement of the synchrony of the thoracic cage and the abdomen is clearly indicating that this high flow is not exerting any effect. And in less than 1 hour, you need to start non-invasive ventilation.
Exactly, I agree. I think the pendulum has come to make us realize that non-invasive ventilation, when we were to sustain therapy for 2 hours without a response, the patient's prognosis of those patients was actually worse. So we learned the lesson by just Dr. Esteban just publishing that data a few years ago, that's saying close monitoring for the first 20, 30 minutes should tell you if the patient is actually responding versus delaying intubation. So it's actually better. There's a question from Kim that is interesting. What is the risk compared to benefit of using high flow nasal cannula or oxygen therapy on a patient who has emphysema? Should we use high flow with patients with COPD?
Oh, yeah. The question is very good. The point is that we have not a lot of experience of that, you know. COPD patients, there are 2 or 3 papers, but not especially those patients with emphysema. Just remember that emphysema is a dynamic airway closing during expiration. So you need positive pressure, the effect for these patients, for the emphysematous patients, are not related to FiO2, but as related to the positive pressure. And high flow, I'm not sure, because the level is variable. Yeah, you can try and just look at the patient, ask the patient if he's comfortable, if the dyspnea is reduced, and according to the results in each patient, maybe you may feel that the pressure is correct or is enough to improve the patient, or you need to apply non-invasive ventilation.
Exactly. I have a question by Robert. Thank you, Robert. And he says, can you comment on the Doshi paper, the non-inferiority study, that concluded lower intubation rate in high-flow nasal cannula group? However, a large percentage of patients were spared by crossing over to non-invasive, which was 88% successful in patients with failing high-flow nasal cannula. And he's also thanking you for a great presentation.
Oh, thank you very much. You're very kind. This is the point that I think all my thoughts goes to this type of studies when you review the paper. The reality of the paper, you can realize that is not like that. Then you go to at the bedside, you don't see the same things. So just make a criticism, put criticism on these papers, and don't trust them. I mean, just write that.
A question from Deborah: should heated non-invasive be used? Applying heat to non-invasive ventilation, there has been always this question that if you're thinking for short-term humidification and heat may not be important. So that's probably the question that she's referring to.
Yeah, you can, that high-flow nasal cannula is oxygen, but is also humidified and also heated. The point is that you can select as well the heating in the device and move from 30 to 37 degrees, and the tolerance improves close to 34, 31 degrees centigrade, right? But anyway, you should apply any technique, humidified and heated oxygen. Otherwise, the patient, the secretions are, doing worse, and this. So techniques are heated and humidified oxygen, of course.
Exactly. I think the point is very well made, because in the past we used to set non-invasive ventilation without heat, thinking that it was just something for a few hours. And I think for the low oxygen therapy has been always debated that maybe low flow, it should be humidified if used chronically, because we have a tendency to undermine or underestimate the effects of not having heated gas. What about, just Javier, there's a question from Elizabeth. How effective is high flow oxygen when given with mask instead of nasal cannula or trach?
The point is that high flow with mask is, without leaks, of course, is a CPAP. So how do you control the pressure inside? High flow is because high flow nasal cannula, the nasal cannula is more comfortable and can be heated, and all this can be controlled. But if you apply a high flow to a mask, if it's an open mask like a Venturi mask, there is no beneficial effect. You are just losing the effects of CO2 clearance and positive pressure. And if the mask is closed, it's non-invasive ventilation, it's a CPAP.
That's a very good point. Hans is asking, may we conclude that non-invasive should be applied in hypercapnic patients and that high-flow oxygen therapy isn't the appropriate therapy of choice in these patients?
This is my point of view. I totally agree with that. But the point is that there are 2 or 3 studies telling that you can improve CO2 in those type of hypercapnic respiratory failure in COPD patients, and the high flow is working correctly. And I understand that the results can be there, but again, be careful with the patient's close monitor. If you want to use it at the first instance, that's correct. I accept it. But just pay attention to the patient and make a blood gas analysis or whatever you wanted to control to see the effect on the patients, staying with the therapy for, let's say, 12 hours.
Exactly. I completely agree. I think before you make a conclusion about just thinking that every single hypercapnic patient will need non-invasive, it just requires a trial. As long as it is monitored, I think it is worthwhile trying high flow with the benefit of CO2 clearance, as explained clearly by Dr. Belda. Felicia, we have applied this therapy early in emergency treatment and have been able to avoid BiPAP and intubations. And so she is complimenting you on great information being shared. And I think the point by Dr. Belda is practice. And as you have to follow the studies, and sometimes the p-value is important, but something that is also very important is when you have a trend to obtain results, that may be sometimes more important than the p-value. And that applies to reintubation rate and so forth. I think we have time for a couple of questions. So Robert has a question. With non-invasive devices that utilize a blower, the FiO2 will determine the need for additional heat. Since a low FiO2, most of the gas is conditioned to ambient and humidity, I guess. So I guess that was more a comment. So let me choose one.
Yeah.
Oh, yes, from Roberta. At what point does the cost of treatment become a consideration?
Well, the point is that I feel that the oxygen is not very expensive, and the air is more expensive. But I think if it's working to treat the patients, if the patient after non-invasive you go to high flow and then to non-invasive, both techniques are, let's say, using a lot of volume, a lot of flow, and you don't feel that you are losing flow when you use non-invasive ventilation. If the technique is effective, I think that is always cost effective because it prevents complications.
Perfect. Let me see. Narina was asking, so how are you defining non-invasive ventilation?
This is a good question and a very odd question. So you feel that if there is a non-invasive is because you don't need intubation. So non-invasive is a high flow nasal cannula. Of course, it's non-invasive, but ventilation is that you ventilate the patient or just you are helping or giving some support to the patient to breathe. This is difficult. CPAP is the CPAP is non-invasive ventilation. Yeah, well, we accept today that outside from intubation, ventilation means instead of ventilation itself, some help to the patient. So in the not oxygen therapy standard oxygen therapy with a mask, but high flow and non-invasive ventilation, CPAP or BiPAP are non-invasive ventilation, but this is a way of speaking.
Exactly. Well, Javier, I wanted to thank you so much for the great presentation. Thank you for over the 800 attendees that we had. So I want to thank Philips again. So let me just hand this over back to Emily.
I'd like to thank you very much for your time, both Dr. Belda, for this extremely informative presentation, and as well to you, Dr. Restrepo, for being our moderator today. It has been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.